afternoon, seniors and friends. At the outset, my sincere thanks and appreciation to Dr. Sami for giving me this opportunity today. So today I'll be speaking to you about endobronchial tuberculosis. It's a topic which is generally not spoken much in terms of when we speak about interventional pulmonology. But actually it is something which is very pertaining for an Indian population because we deal with a lot of patients of tuberculosis. So there are no disclosures, and this is the hospital from where I come from. It's Yashoda Hospital, Somajiguda in Hyderabad. So endobronchial TB is nothing but a tuberculous infection of the tracheobronchial tree with microbiological and histological evidence, which essentially means that you need to demonstrate the tubercular bacilli along with the granulomatous inflammation from an endobronchial biopsy. So it was first described by Richard Morton in the year 1698. And if you see the incidence in the Western population, it is somewhere between 6 to 54%. But when it comes to TB endemic region, some form of an endobronchial TB can be even seen as high as 80 to 90% of your patients. And generally the stenosis which is associated with the endobronchial TB, 68% occurs in the first 4 to 6 months. But the important point to note is, even after your completion of an ATT, your patient may be at a risk of developing an endobronchial stenosis. So a proper follow-up at least 2 years is something which is warranted. And generally it is difficult to diagnose because neither your CT nor your clinical examination can really pick it up with that much amount of sensitivity. So one important modality which remains a cornerstone for diagnosing these endobronchial TB is your bronchoscopy. And generally when it comes to the characteristics of the endobronchial TB, it predominantly occurs in the female. And it generally occurs in the left main bronchus because the left main bronchus are generally narrower, and longer the exposure to the tubercular bacilli, the more is the risk of developing an endobronchial TB. And generally it occurs in a woman between second or third decade, and generally the second peak occurs in the elderly population. And most of the endobronchial TB generally resolves with your ATT with some amount of steroids, but a certain fraction of an endobronchial TB can go in for the disabling endobronchial stenosis. And as I said to you before, it can involve any part of your bronchi, be it the primary bronchi or the bilateral superior lobar bronchi or the right middle lobe bronchus. And depending upon the level of the involvement, it can be a single level endobronchial TB where there is an isolated lesion. But generally what we observe in the clinical practice is more of a multi-level endobronchial TB. That means even in the bronchus, you can have the stenosis at the multiple levels. And we call it as a central stenosis if it involves still the level of the bronchus intermedius. And the peripheral stenosis can be in the form of the segmental and the subsegmental bronchi. And generally it can present with mucosal or the submucosal ulcerations, granulomas, fibroplasias, and even stenosis. So there are a lot of pathogenesis which are attributed to the development of an endobronchial TB. One, it can be because of the direct extension of the bacteria from the parenchyma into the airway, or it can be the implantation of the organisms from the infected sputum. Very rarely you can even have a hematogenous dissemination causing the endobronchial TB, or you can have a broncolith sort of a formation where the lymph node erodes into the bronchus, or there can be a spread of the infection via the lymphatics. And if you see the symptoms, if a patient of a TB has a consistent cough which is not getting responded to the treatment, then always have in your back of the mind that the patient may be suffering from an endobronchial TB, and generally this cough tends to be a dry cough. And hemopsis can be seen in 15 to 40% of the patients, and localized wheezing and decreased breath sounds. This is very, very important. Let's say that you have a patient who is on treatment with TB. The patient is having a consistent cough and you auscultate and you are able to demonstrate a localized wheezing or there is presence of a decreased breath sounds, then always have a very high suspicion of an endobronchial TB in these patients. Along with that, they can have all the other constitutional symptoms like fever, anorexia, generalized weakness, and weight loss. How are we going to diagnose this endobronchial TB? So people are trying to use multiple modalities like sputum, but sputum is positive only in 16 to 53% of patients. So there is a hypothesis which says that in endobronchial TB, the bacteria is engulfed by the granulation tissue and the inflammatory process. So generally your sputum tends to be negative. And however, with the advent of these gene expert, you can still diagnose many of these cases of endobronchial TB. But one important modality which really helps us to identify which patient should be subjected to bronchoscopy is your CT scan. So in your CT scan, if you are able to demonstrate a bronchial narrowing, or if you are able to demonstrate an endobronchial obstruction, or if you are able to demonstrate a lymph node eroding into the bronchus, then these are the signs which may indicate probably your patient may be suffering from an endobronchial TB. But whatever having said and done, the only modality which can confirm the presence of an endobronchial TB is your bronchoscopic method. So in bronchoscopy, you can have multiple varieties of presentation. It can be a non-specific bronchitis where the tracheobronchial tree is only mildly edematous. Sometimes you can have an edematous and a hyperemic variety where there is both an edema as well as increased area of vascularity in the airway. And one important thing which can immediately give you a clue that you're dealing with an endobronchial TB is the cacheating type. If you see a bronchus like this with a lot of cacheation, then probably these are the endobronchial TB variants which can go in for a stenosis. Sometimes you can have a granulation tissue like this. You can have a tracheobronchial mucosa which is filled with rice-like granules. And sometimes you can have an ulcerative variety where there is a tracheobronchial mucosa ulceration. And there can be a tumorous form of an endobronchial TB. We had 2 patients where we doubted malignancy, looked like a classical tumor. In the end, it turned out to be a granulomatous inflammation with a gene expert positivity. So your TB in the endobronchial lesions can present as any forms. But the most dreaded phenotype that where the interventional pulmonology plays a very important role is in the fibrostenotic variety. So if this inflammation goes on for a very long period of the time, ultimately it scars and results in a stenosis. And this causes a complete occlusion of the bronchi and the patient may even lose one entire lung. So when it comes to the management of the endobronchial TB, ATD forms the cornerstone of the treatment. But to prevent the stenosis from occurring, if you diagnose the endobronchial TB at a much earlier time, you can start these patients on a concurrent dose of steroids. This is very, very important. If just like how you have a pericardial effusion and a tuberculosis, you start the patient on steroids. The moment you diagnose a patient with an endobronchial TB with your bronchoscopy, it is advisable to start these patients on steroids. There are different school of thoughts that one of the guidelines says that you need to start at 40 to 60 milligram daily for 4 to 6 weeks and taper. But generally in India, we don't give that much higher dose of steroids, fearing there could be a worsening of your underlying tuberculosis as well. And steroids generally reduce the bronchial narrowing and reduce the extent of the post-stenotic lung damage. And they may also reduce the long-term evaluation of the high-grade bronchial stenosis. So I'll just take you through a few of the cases which we found in our clinical practice and let's see how we handle these cases of endobronchial TB. So this was a patient who was a 43-year-old female, no comorbidities, treated as a case of an uncontrolled asthma for 3 months, presented to us with a shortness of breath, wheeze and cough with minimal expectoration. You got a X-ray done and a CT chest done. If you see the CT scan, there is presence of a tree in bud nodularity in the right upper lobe and there is slight narrowing of your trachea. So we took up this patient for a bronchoscopy and what you are seeing is nothing but an actively cacheating sort of a endobronchial TB. If you have not done a bronchoscopy for this patient and if you have treated with only ATT, this possibility of developing into a later stage of a stenosis is quite high. So we took a biopsy and a BAL to confirm the presence of an endobronchial TB. As you can see from here, there is presence of AFB along with the granulomatous inflammation. And we started this patient with ATT and steroids. And after end of 6 months, you see there is a larger resolution, but still there is certain amount of cacheation. So the important point to note is whenever you have a patient like this, you need to keep this patient on follow-up because the stenosis doesn't stop at 6 months. We have seen a patient who has completed his entire course of ATT. 2 years later, the patient presented to us with a stenosis and the patient was having a stridor as well. So this is second case who is a 23-year-old male non-smoker. He had a history of sputum positive tuberculosis 3 years back and he completed 6 months course of an ATT. There was no history of any invasive mechanical ventilation. This time the patient after 3 years of completion of ATT present to you with hoarseness of voice and exertional breathlessness and you got a CT chest done, there is evidence of a subglottic stenosis. So this is a very important finding because now you know that the TB is over. So you are a little relaxed. But 3 years later, this patient presented with an endobronchial TB. This time it was presenting like a subglottic stenosis. So there was a concentric narrowing of your trachea. So in these cases, our intervention really plays an important role. So what we are doing here is we are making the electrosurgical incisions with the help of the electrosurgical knife. And we are trying to open up the stenosis, thereby preventing this stridor from happening. So the important point is even when you do any of these bronchoscopic methods, you need to keep this patient on follow-up because the chance of recurrence is going to be high. So to prevent the recurrence, what we are doing is called as a cryoablation of the stenosis. This is something which we started at our center. So once we dilate the airway, we use this cryoablation so that it causes the destruction of the fibrotic cells and prevents the chances of restenosis. And what we are doing here is nothing but a classical balloon bronchoplasty, which means we take the CRE balloon, we dilate the airway, and we make sure that the airway is appropriately dilated. Again, as you can see from here, we are using the cryoablation so that the restenosis doesn't happen. And sometimes we even give an intralesional steroids. And now you can see in this case, what we are doing will be an endobronchial application of a mitomycin. So once the stenosis is adequately dilated, now what we are doing is we go there, we place this anti-neoplastic agents like a mitomycin so that the stenosis does not occur. So we are applying the mitomycin at the stenotic base. So this is a very rare case of a tuberculosis stenosis. That patient completed 3 years of had a TB 3 years before, later presented with an isolated tracheal stenosis. Similarly, your stenosis can occur at multiple levels. So right now, this case, what we are going to see shows the presence of a complete stenosis of the right upper lobe. Now you can see there is a patient who is having a right upper lobe collapse, but luckily in the CT scan, you are able to see some amount of a distal airway. So we did a bronchoscopy for this patient, and now you can see that the right upper lobe is almost near completely obliterated by means of the granulation tissue, suggesting some sort of a form of a stenotic variant of a endobronchial TB. Now you can see I am able to pass the scope into the right bronchus intermedius, but there is literally no right upper lobe. If we leave it like that, this patient can go in for a permanent collapse of his right upper lobe. So what we do in these cases is we do the bronchoscopic recanalization of the airway. Now you can see there is no right upper lobe. It is entirely covered by means of the granulation tissues occurring secondary to an endobronchial TB. So what we are doing in this case is we are trying to open up the right upper lobe, because we know that the distal lung is viable because there is certain amount of an aeration in the distal lung. So initially we are passing the Fogarty balloon to open up this airway. And now you will be seeing that as we are opening up the airway, the pus which is contained in the distal airway will start coming out. So we are using this Fogarty balloon. These are little technically challenging cases because it takes a lot of time. What we are showing is a 2 or 3 minute video, but generally it takes hours in the OT. Now you can see that once I opened up the little bit portion of the right upper lobe, I am passing the CRE balloon and I am dilating with the help of the CRE balloon. And once the CRE balloon is dilated, now you will be seeing that the pus which has collected distally is exuding, and I am later removing all the granulation tissue with the help of the cryoprobe. And now you can see a right upper lobe which was not there, it has now become almost near completely recanalized, and the right upper lobe is also saved, and we are even able to see the distal subsegments. So whenever you have a patient like this, do not think that we need to leave these lesions like this. Now with the help of these bronchoscopic modalities, you can completely salvage this upper lobe, and now you can see that there is a near complete opening, and this patient is on follow-up for 1 year. We required 2 or 3 more episodes of dilation, but the stenosis did not cause the closure of your right upper lobe bronchus. Similarly, in the interest of the time, I'll take you through one last case to make you understand how severe your endobronchial TB can be. So this patient actually came to us all the way from Bengal. The X-ray you are seeing here was the X-ray which was done before the initiation of a sputum positive tuberculosis. The patient was started on ATT. The patient completed 6 months of ATT, but at the end of the treatment, patient became oxygen dependent. So what essentially happened was the patient had an endobronchial TB which was missed. Patient was treated only with ATT. This resulted in a complete stenosis of the left entire main bronchus. And a patient who was maintaining normal oxygen at the end of the treatment had one completely collapsed lung, and he was maintaining only 82 to 83% on room air, and he was put on oxygen. And this patient roamed around for almost 6 months and then came to us. So when the patient came to us, it was quite interesting because what you can see that at the end of the treatment, there is a complete closure of the entire left main bronchus and there is no left lung. So after 6 months, salvaging the lung is very difficult. You don't know whether the lung is going to be salvaged or not. We took up this patient, we did a bronchoscopy, and in the bronchoscopy you can see there is no left main bronchus. There is only you are able to see a remnant of a carina, and the bronchus is directly leading into the right main bronchus. Recanalizing these airways are quite difficult because while giving electrosurgical incisions, if you are wrong, you may inadvertently enter into the mediastinum and you really don't know the distal lung is going to be patent or not. So what we are doing initially is the blunt dissection of the airway. So we use these Fogarty balloons to cause the blunt dissection of the airway. And luckily we were in the right tract and we were able to open up the airway. And once this airway is open, right now you are seeing that we are using the balloon to further expand the airway. And once it is done, we are able to define the path, but the hole is quite small. So what we are doing is we are making some electrosurgical incisions to open up the airway, and once it is done, now you are seeing that we are putting a guide wire to see if it is actually going inside the lung or not, and it is not going inside the mediastinum. Once we know that we are in the correct plane of dissection, then what we are doing is we are inflating with the help of a CRE balloon. And once CRE balloon is inflated, now you can see that lot of pent up pus which was there and mucus secretion which was there in the distal segment is retracted, and now you can see that the airway is completely open, and we are even able to pass our bronchoscope, and we are even able to define all the subsegments in the distal plane. So we thought that the lung may not expand because the surfactant would have gone, because the collapse was there for almost around 6 months. But you will be seeing, to our surprise, this patient was extubated on table and his saturation was 94, an X-ray which was looking like this. Immediately post procedure, there was a complete expansion of the left lung, and this patient is almost 2 years into follow-up. Now the patient is having a complete expansion, and a patient who was considered to be oxygen dependent is now moving and doing all his activities by himself. This was an extreme case of a complete endobronchial stenosis of the left main bronchus due to tuberculosis, but you will not be successful in all cases. The lucky part for this patient was the distal lung was not infected, so there was no post-obstructive pneumonia. But there are cases where even after opening the airway, we will not be able to salvage the lung. So in the interest of the time, I'll end my presentation here. This is our team at Ashoda Hospitals. We run a fellowship program, and this is our IP suite, and this is our website where we put all our cases. So if anybody is interested, can go through it. Thank you.